Cellular growth adaptations, how cells respond to changing conditions. Cellular adaptations are structural and functional changes that cells undergo in response to various stimuli, including environmental changes, hormonal signals, physical stress, injury, and disease. Understanding these cellular adaptations is crucial in pathology and medicine, as they help explain how tissues respond to different conditions. In this video, we'll cover the major types of cellular adaptations. These include hyperplasia, an increase in cell number; hypertrophy, an increase in cell size; atrophy, a decrease in cell size; metaplasia, a change in cell type; dysplasia, abnormal cell growth; aplasia, complete developmental failure; and hypoplasia, incomplete development. Understanding these cellular adaptations is crucial in medicine and pathology. They serve as diagnostic indicators, reflect how cells respond to stress, help predict disease progression, and guide treatment approaches. Hyperplasia is an increase in the number of cells in an organ or tissue. This growth adaptation occurs through increased cell division, specifically mitosis, in response to specific stimuli. During mitosis, a parent cell divides into two identical daughter cells. Unlike cancer, hyperplastic growth is controlled and reversible when the stimulus is removed. The tissue architecture remains normal during hyperplasia. Cells maintain their typical appearance and function. Hyperplasia is a fundamental adaptive response that allows tissues to meet increased functional demands. Physiological hyperplasia refers to the normal, controlled increase in cell numbers that occurs as part of healthy bodily functions. One common example is breast development during puberty and pregnancy. In response to hormones like estrogen and progesterone, breast tissue undergoes significant hyperplasia, increasing the number of epithelial cells. Another example is the cyclical growth of the endometrial lining during the menstrual cycle. Under hormonal influence, the endometrium grows from 1 to 2 millimeters thickness to 5 to 7 millimeters, preparing for potential embryo implantation. A remarkable example of physiological hyperplasia is liver regeneration. After partial hepatectomy, where up to 70% of the liver is removed, the remaining cells proliferate to restore normal liver mass within weeks. Unlike pathological processes, physiological hyperplasia is tightly regulated. It has clear starting and stopping signals, is reversible when the stimulus ends, maintains normal tissue architecture, and serves as an adaptive response to specific physiological needs. Pathological hyperplasia is an abnormal increase in the number of cells in response to abnormal stimuli. Unlike physiological hyperplasia, pathological hyperplasia occurs due to abnormal signals and may require medical intervention. Let's examine some important clinical examples of pathological hyperplasia. Benign prostatic hyperplasia affects older men, causing enlargement of the prostate gland and urinary symptoms. It results from age-related hormonal changes and may require medication or surgical intervention. Endometrial hyperplasia is characterized by thickening of the uterine lining due to excess estrogen. It can cause abnormal uterine bleeding and increases the risk of endometrial cancer. Skin hyperplasia occurs in response to chronic irritation, as seen in conditions like psoriasis and eczema. It presents as thickened, scaly skin and may be reversible if the irritant is removed. Pathological hyperplasia can lead to several complications and requires appropriate management. Potential complications include functional impairment of affected organs, progression to dysplasia, and in some cases, an increased risk of cancer development. Management approaches focus on removing the underlying stimulus, using pharmacological interventions, surgical removal if necessary, and regular monitoring to detect any progression to more serious conditions. Histopathologically, pathological hyperplasia shows distinct features compared to normal tissue. Pathological hyperplasia demonstrates increased cell density while maintaining tissue architecture. Importantly, cells retain normal morphology without nuclear atypia, distinguishing it from dysplasia and neoplasia. Hypertrophy is defined as an increase in the size of individual cells, resulting in an enlarged organ or tissue without an increase in cell number. We can see this demonstrated when comparing a normal cell to a hypertrophic cell. Notice how the hypertrophic cell is significantly larger in size. Hypertrophy occurs when cells synthesize more structural components. The hypertrophic cell contains increased proteins, more organelles, and additional cytoplasmic components. These enhancements make hypertrophic cells functionally more capable of handling increased physiological demands placed on the tissue or organ. Physiological hypertrophy is a normal adaptive response where cells increase in size due to increased functional demand. In hypertrophy, cells grow larger without increasing in number. The increased size allows for enhanced function. The classic example of physiological hypertrophy is skeletal muscle growth during exercise training. Muscle fibers enlarge to generate more force through increased protein synthesis. Another example is cardiac muscle hypertrophy in athletes, commonly known as athlete's heart. During regular, intense training, the heart muscle strengthens to pump more blood effectively during physical activity. Importantly, physiological hypertrophy is reversible with detraining, preserves normal function, and enhances performance without pathological changes. Pathological hypertrophy occurs in response to disease states, causing cells to abnormally increase in size. Unlike normal cardiac cells, hypertrophied cells show a dramatic increase in size due to a sustained disease stimulus. A prime example is cardiac hypertrophy due to conditions like hypertension or valve disease. The heart muscle enlarges to overcome increased resistance. Unlike physiological hypertrophy, which is adaptive and beneficial, pathological hypertrophy follows a progression that often leads to impaired function over time. At the cellular level, pathological hypertrophy involves increased myocyte size, sarcomere reorganization, and fetal gene reactivation. These changes ultimately lead to fibrosis, abnormal calcium handling, and mitochondrial dysfunction. Pathological hypertrophy has significant clinical implications. It serves as a marker of cardiac disease progression and can predict adverse outcomes. The most common examples include left ventricular hypertrophy due to hypertension and hypertrophic cardiomyopathy. Unlike physiological hypertrophy, pathological hypertrophy often leads to impaired cardiac function over time and may progress to heart failure if the underlying condition remains untreated. Comparing hyperplasia and hypertrophy, two fundamental cellular growth adaptations. Hyperplasia increases the number of cells through division. Hypertrophy, in contrast, increases the size of existing cells. Let's examine the key differences between these two adaptations. Interestingly, some tissues like the uterus during pregnancy can undergo both hyperplasia and hypertrophy simultaneously. However, the response is often tissue-specific. Mature neurons can only undergo hypertrophy, while tissues with stem cells primarily favor hyperplasia. Atrophy is a cellular adaptation characterized by a decrease in cell size, leading to shrinkage of an organ or tissue. In normal cellular conditions, cells maintain their size through balanced protein synthesis and degradation. During atrophy, cells reduce their structural components and become smaller, though they maintain their basic architecture. Atrophy occurs through several key cellular mechanisms. First, there is increased protein degradation. Proteins within the cell are broken down at a higher rate. Second, there is decreased protein synthesis. The cell produces fewer new proteins to replace those being degraded. Third, cellular organelles may be broken down through a process called autophagy, where the cell digests its own components. As a result of these processes, atrophy leads to several key changes in the affected tissue. The cells become significantly smaller in size. These smaller cells have reduced functional capacity. However, it's important to note that despite these changes, the basic tissue architecture remains intact, distinguishing atrophy from more severe forms of tissue damage. In summary, atrophy is a reversible adaptive response where cells decrease in size through protein degradation, decreased synthesis, and autophagy, resulting in smaller but structurally intact tissues. Atrophy is the decrease in cell size resulting in a decrease in tissue or organ size. There are 5 major causes of atrophy, each with distinct mechanisms and clinical presentations. Disuse atrophy occurs when a tissue isn't used regularly, such as muscles immobilized in a cast or in bed-bound patients. Denervation atrophy happens when nerves supplying a tissue are damaged, as seen in peripheral neuropathy or spinal cord injuries. Ischemic atrophy results from reduced blood supply to tissues, as seen in chronic kidney ischemia or coronary artery disease. Hormonal atrophy occurs with hormone deficiency, such as endometrial tissue atrophy after menopause or in thyroid hormone deficiency. Nutritional atrophy develops during malnutrition or starvation. The lack of essential nutrients leads to cellular breakdown and reduced cell size, affecting multiple organs, particularly muscles. To summarize, the 5 major causes of atrophy are disuse from lack of activity, denervation from nerve damage, ischemic from reduced blood supply, hormonal from hormone deficiency, and nutritional from malnutrition or starvation. Clinical examples of atrophy present in various tissues and organs, with distinct manifestations and degrees of reversibility. Muscle atrophy commonly occurs in bedridden patients. Disuse leads to decreased muscle mass, but this can often be reversed with appropriate physical therapy and exercise. Brain atrophy is a hallmark of Alzheimer's disease and other neurodegenerative conditions. It involves cortical thinning and ventricle enlargement, and is typically irreversible with current treatments. Thymus atrophy, or involution, is actually a normal physiological process associated with aging. The thymus gradually reduces in size and is replaced by fat tissue, leading to decreased immune function. Gastric mucosal atrophy often develops in chronic gastritis, particularly with Helicobacter pylori infection. This condition increases the risk of gastric cancer and may be partially reversible if the underlying infection is treated. The reversibility of atrophy largely depends on timing and underlying cause. Early intervention may reverse atrophic changes in some tissues, particularly muscle. However, chronic, long-standing atrophy often becomes permanent, as seen in advanced neurodegenerative diseases. Treatment strategies typically focus on addressing the underlying cause rather than directly targeting the atrophic process itself. Metaplasia is a cellular adaptation where one differentiated cell type is replaced by another mature cell type that is not normally present in that tissue. In this process, you can observe how one normal cell type transforms into a different mature cell type that wouldn't normally be found in that tissue location. Metaplasia occurs through a specific mechanism. Stem cells, which normally differentiate into the tissue's standard cell types, alter their differentiation pathway in response to chronic stress or irritation. Metaplasia serves as an adaptive response that makes tissues more resistant to environmental stress. It's a protective mechanism and is generally reversible if the irritation is removed. However, if the stress persists, metaplasia can potentially predispose tissues to cancer development due to altered gene expression and continued cellular stress. Let's examine the common examples of metaplasia, a cellular adaptation where one mature cell type is replaced by another. The most common example is intestinal metaplasia in the stomach. In this condition, normal gastric epithelium is replaced by intestinal type epithelium. Note how the cell structure changes completely. This adaptation is primarily caused by chronic Helicobacter pylori infection or persistent gastroesophageal reflux. Another important example is squamous metaplasia in the respiratory tract. In the respiratory tract, ciliated columnar epithelium normally lines the airways. When exposed to irritants, this epithelium transforms into squamous epithelium, losing the cilia that help clear mucus and pathogens. This transformation is typically triggered by cigarette smoke, chronic inflammation, or other environmental irritants. Both types of metaplasia have important clinical implications. Intestinal metaplasia in the stomach is considered a precancerous condition associated with an increased risk of gastric cancer and requires regular surveillance. Squamous metaplasia in the respiratory tract reduces mucociliary clearance, increases susceptibility to infections, but may be reversible if the irritant is removed. Understanding these common examples of metaplasia helps clinicians recognize and manage these important cellular adaptations. Dysplasia refers to abnormal cellular growth with altered size, shape, and organization. To understand dysplasia, let's compare normal and dysplastic cells. Normal cells have a uniform size and shape with regular nuclei and organized arrangement. In contrast, dysplastic cells show significant abnormalities. They vary in size and shape, with enlarged and irregular nuclei. Dysplastic cells exhibit several key characteristics. These include nuclear abnormalities, such as enlarged nuclei and irregular nuclear membranes. Abnormal chromatin patterns appear within the nucleus. The tissue architecture becomes disorganized, and there is a loss of normal cellular orientation and maturation. Importantly, dysplasia represents a step toward neoplastic transformation, existing on a spectrum of cellular abnormalities. The progression begins with normal tissue, advancing through mild, moderate, and severe dysplasia, potentially leading to cancer. Dysplasia is typically graded as mild, moderate, or severe, based on the degree of cellular abnormalities and architectural distortion. Mild dysplasia shows minimal abnormalities confined to the basal layer of the epithelium. In moderate dysplasia, abnormalities extend to the middle third of the epithelium with more pronounced nuclear changes. Severe dysplasia, also called carcinoma in situ, shows marked abnormalities throughout the full thickness of the epithelium. Comparing all three grades side by side demonstrates the progressive nature of dysplastic changes from mild to severe. A critical distinction in all grades of dysplasia is that despite cellular abnormalities, there is no invasion through the basement membrane. Once cells break through this barrier, the diagnosis changes to invasive carcinoma. To summarize, dysplasia grading reflects the extent of cellular abnormalities within the epithelium, from minimal changes in mild dysplasia to full-thickness involvement in severe dysplasia or carcinoma in situ. Dysplasia is clinically significant due to its potential to progress to invasive cancer. Let's examine three important examples. Cervical dysplasia is primarily caused by persistent human papillomavirus infection. It's detected through routine pap smear screening, which has dramatically reduced cervical cancer rates. The severity is classified from low-grade to high-grade squamous intraepithelial lesions, or SIA in grades 1 through 3. Colonic dysplasia is commonly seen in patients with long-standing inflammatory bowel disease. These patients require regular surveillance colonoscopies to detect precancerous changes. The risk increases significantly after 8 to 10 years of disease. Oral dysplasia often presents as leukoplakia, which appears as white patches in the mouth. There's a strong association with tobacco use, both smoked and smokeless forms. Diagnosis requires biopsy, as clinical appearance alone cannot determine the degree of dysplasia. Early detection of dysplasia is crucial in all these examples. Regular screening for high-risk populations, appropriate biopsy of suspicious lesions, and established surveillance protocols can prevent progression to invasive cancer. The goal is always to intervene before malignant transformation occurs. Aplasia refers to the complete developmental failure of an organ or tissue. In aplasia, there is a complete failure of an organ or tissue to develop due to the absence or failure of precursor cells during embryonic development. To understand aplasia, let's compare normal embryonic development with aplastic development. In normal development, precursor cells are present and functional during embryonic development. These precursor cells divide and differentiate to form the organ or tissue. In aplasia, however, the precursor cells are either absent or completely non-functional. As a result, no development occurs, and the organ or tissue is completely absent. Let's review the key characteristics of aplasia. Aplasia results in the complete absence of the affected tissue or organ. It is typically congenital, meaning it is present at birth. Aplasia results from the failure of precursor cells during embryonic development. Unlike some other cellular adaptations, aplasia cannot be acquired later in life. Aplasia refers to the complete failure of an organ or tissue to develop. Let's examine some important clinical examples. Renal aplasia is the complete absence of one or both kidneys due to developmental failure. Bilateral renal aplasia is incompatible with life, while unilateral cases may be asymptomatic if the remaining kidney functions normally. Thymic aplasia, most commonly seen in DiGeorge syndrome, involves the complete absence of the thymus gland. This results in severe T-cell immunodeficiency, typically caused by a deletion on chromosome 22q11.2. Patients often have associated parathyroid and cardiac defects. Pulmonary aplasia refers to the complete absence of lung tissue, bronchus, and pulmonary artery on the affected side. It is typically unilateral and compatible with life. Many cases are detected incidentally on imaging, while others present with respiratory symptoms. Aplasia cutis congenita is characterized by localized absence of skin, typically present at birth. It most commonly affects the scalp, appearing as well-demarcated ulcers or scars. This condition may be isolated or associated with various genetic syndromes and other malformations. Management of aplasia typically requires a multidisciplinary approach. This includes early detection through imaging and genetic testing, coordinated care teams, possible surgical interventions, and regular monitoring for complications. Hypoplasia refers to the underdevelopment of an organ or tissue due to decreased cell production during development. Unlike aplasia, where an organ completely fails to develop, in hypoplasia, the organ forms but remains smaller than normal. Hypoplastic organs may have reduced or impaired function. The severity often depends on the degree of underdevelopment. Hypoplasia can result from several factors. These include genetic abnormalities, which can affect normal organ development. Intrauterine growth restriction occurs when a fetus doesn't receive adequate nutrition or oxygen during pregnancy, limiting development. Exposure to toxins such as alcohol, certain medications, or environmental chemicals during critical developmental periods can disrupt normal growth. Finally, vascular insufficiency, where blood supply to developing tissues is compromised, can lead to hypoplastic organs. Common examples of hypoplasia include pulmonary hypoplasia, where the lungs are underdeveloped, and thymic hypoplasia, seen in DeGeorge syndrome. Other examples include focal dermal hypoplasia, affecting skin development, and mandibular hypoplasia, where the lower jaw is underdeveloped. It's important to note that hypoplasia is a developmental abnormality that occurs before birth, not an adaptation of mature tissue to stress or injury, like other cellular changes we've discussed. Understanding hypoplasia helps clinicians identify developmental issues early and plan appropriate management strategies. Clinical examples of hypoplasia demonstrate the impact of underdevelopment across various organ systems. Pulmonary hypoplasia represents underdevelopment of the lungs, often secondary to conditions that limit expansion in utero, such as oligohydramnios or diaphragmatic hernia. This condition can be unilateral or bilateral and is associated with respiratory distress immediately after birth, with a high mortality rate in severe cases. Cerebellar hypoplasia involves incomplete development of the cerebellum, which can result from genetic factors, infections, or ischemic events during development. This manifests clinically as motor coordination problems, including ataxia, tremors, poor balance, and speech difficulties, depending on which cerebellar regions are affected. Enamel hypoplasia represents defective formation of tooth enamel, which can be caused by environmental factors such as malnutrition, infections, trauma, or exposure to toxins during tooth development. This results in teeth with pitted, grooved, or discolored surfaces, leading to increased susceptibility to dental caries and other complications. Thymic hypoplasia involves underdevelopment of the thymus gland, a critical component of the immune system. It is often part of DiGeorge syndrome, associated with a deletion on chromosome 22q11.2. This results in decreased T-cell production, leading to immunodeficiency and increased susceptibility to infections. Patients may require immune system support or even thymus transplantation in severe cases. Across all examples of hypoplasia, the severity of symptoms depends directly on the degree of underdevelopment. More significant hypoplasia typically leads to more severe clinical manifestations.
If you found this video helpful, we invite you to visit our website. There, you can see all the subjects well classified and you can gauge your knowledge by online quizzes. Learn wiser, test yourself, and be prepared. Easy.